So welcome to all of you and welcome to the Thorne Prize. And this is our agenda for the day. We are running about 10 minutes behind, so just push all these times except for the prize winners announcement. So we will kick it off here with Fulcrum Care, and then going next with Team Pixie Quest, Project Hope, and then ending with Respond Crisis Translation. And then we will have all of you audience members fill out your audience choice card and drop it in the ballot box near the door back there while our judges deliberate. And then the winner will be announced this afternoon after the alumni fireside chat. So again, thank you all so much for being here. Forgot to introduce myself. I have had a lot of caffeine this morning, and I have a 2-year-old, so get that. My name is Fatima Bastrai. I'm the Managing Director of Innovate Health Yale, and this is my 6th Thorne Prize. So I have been here for more than half of Startup Yale and Thorne Prizes, which is very exciting. And a big thank you to our judges who are joining us, and they are seated in the front row. We have Margaret Yates Thorne, David Thomas, KP Yalpala, and Leslie Asanga. These folks have been joining us, most of them for several years, so very excited to have all of them here. And with that, I think we are ready for our first team. Come on up.
Hi, I'm Lori Jimenez.
And I'm Adam Crittenden, and we're Fulcrum Care.
I'm a practicing dental hygienist, and today we're here to tell Dorothy's story. Dorothy has not seen the dentist in many years, and she's experiencing a lot of dental pain. She can't find a dentist who accepts her public insurance, and she's concerned because her primary care doctor has warned her that her poor oral health could impact her chronic conditions. She's finally able to schedule an appointment through a private insurance, but she has trouble getting there. And the result of her visit is an extensive treatment plan that requires multiple in-person visits and out-of-network referrals. Dorothy feels that getting the dental care that she needs is out of her reach. And Dorothy is not alone. 1 in 5 dual-eligible patients like Dorothy who are enrolled in both Medicaid and Medicare insurance report not being able to get needed dental care. And even though over the years, innovation in healthcare has focused on closing care gaps, dental care is often overlooked. Fulcrum Care aims to close this dental care gap. Imagine that instead of Dorothy having to find a dentist who accepts her insurance, her primary care doctor is able to seamlessly refer her to Fulcrum Care, an in-network provider. And instead of Dorothy having to struggle with transportation barriers, her Fulcrum Care clinicians can deliver care in the comfort of her own home. And instead of Dorothy having to memorize her medications and medical history, her Fulcrum Care team has access to her electronic health records. We are building a new care model from the ground up. The first component is that we're hiring mission-driven dental providers and enabling them to deliver compassionate care to Medicaid and Medicare patients. The second component is that we're partnering with primary care teams who are committed to improving whole person outcomes, including oral health. And the third component is that we're eliminating operational barriers to delivering care by leveraging a chair rental model and portable dental units. This model positions Fulcrum Care to be aligned with broader healthcare priorities towards value-based and patient-centered care for Medicaid and Medicare patients.
Tactically, how are we going to do this? To break down barriers to care and to scale Fulcrum Care's unique care model, we must clearly prove the link between dental and medical outcomes. We aim to prove that $1 spent on dental care saves many multiples on downstream medical costs. If Dorothy doesn't receive dental care and she ends up in the ER, that'll cost the health system a lot more money than had she received dental care to begin with. By proving the clear link here, we aim to sign contracts with risk-bearing primary care practices and payers who have a financial stake in ensuring access to care. But we do have to prove this link. which is why we're launching a clinical pilot. By providing oral health services to the established patients of an existing risk-bearing primary care practice, we aim to pilot Fulcrum Care's unique model with low customer acquisition cost for a patient population with existing fee-for-service reimbursement under the current system. Lori and I have been working on Fulcrum Care for a year now. Since then, we've built out the technological infrastructure necessary to deliver our care model. This culminated in a big win last winter, establishing a data pilot partnership with Connie, the Health Information Exchange for the state of Connecticut. Through this partnership, we're able to access the longitudinal health record for our patients and to share relevant dental data with their physicians. Now, we've joined the Sci-City Summer Fellowship, where we have a clear goal ahead: establish our clinical pilot partnership and launch by the end of the summer. The Thorne Prize would be catalytic in this goal. The Thorne Prize would enable us to rent out chair space in an existing dental practice nearby and to build out our population health analytics capability. But more than any line of code or any specific chair, it would allow us to have a clear signal of our commitment to underserved communities, a signal which is especially important as we launch our clinical pilot partnership. Lori brings her expertise as a dental hygienist. I bring my passion for the effective and the ethical use of data, a passion which is grounded in practical experience building and leading analytics teams at healthcare systems. We are fortunate to be joined by a fantastic team of advisors, including Dr. Barry Chase, a dentist with decades of experience, and Dr. Chima Ndumale, whose work at WisePH informs our approach to navigating Medicaid policy. Together, we can break down barriers to dental care for underserved communities, and we welcome you all to be a part of that change.
Have you explored this with any of the payers in terms of the proof statements they're looking for from you to sign on to something like this?
Of course.
Yeah, so I've had conversations with executives of insurance plans, and an example is like Humana, and they recommended that what they want to see is a pilot. They want to see us to be able to prove outcomes, which is why we're really focused on tracking quality metrics and outcomes of patients. And they said that once we can do that, they're more interested in potentially financing the care model through value-based arrangements.
Yeah, I think quality metrics is our biggest thing here, making sure that there's access to care. Obviously, the metrics that we track would vary a little bit on a partnership by partnership basis. But at the end of the day, we've built out the infrastructure to be able to track these metrics. It's a question of figuring out which metrics are going to be tracked depending on the contracts we're going into. But that also is very tied to our scaling phase. We view the pilot phase. We partner with an established primary care practice, prove those outcomes, and then scale from there.
So just building on that, and it's great. What's unique about the model to drive the outcome, right? Is it simply just getting care to people that don't have it? And then how long is it going to take you to measure to the outcome?
Yeah, I think one of the big pieces there is interoperability. Most dental practices right now are not sharing information between physicians and dentists, and we're very clear in the ways that there are gaps between the dental systems and the medical systems. I'm also a twin. My twin sister's a dentist, and so that's how Laura and I actually started working together. But I'm very aware of the ways in which there are very different data standards, but more than just data standards, there are some fundamental differences. People get trained in different schools, and while there has been a lot of work to have closer integration between the two, I think that integration point, that interoperability point really grounds what we're doing. And we're also willing to learn from other organizations like CityBlock and Oak Street, who have done a tremendous amount of work about improving access to care through logistics, through transportation. And so between interoperability and logistics, I think those are two key differentiators.
And I'd like to add to that point just by my personal experience as a dental hygienist for nearly a decade, the experiences that I always saw with patients, my lowest income and my older patients that had Medicaid and Medicare always had the worst oral health, and it was really the hardest part that they had was getting in the door, because finding a provider that accepted insurance, Medicaid, Medicare doesn't offer coverage, and then even Medicare Advantage plans, not a lot of dentists will take that insurance. So it's eliminating those barriers and also being creative in how are we bringing the care to the patient, right? Community-based or bringing it to their home. Those are ways that we are ensuring that we can actually eliminate these barriers to care.
So I wanted to follow up on that, the bringing it to the home part, because you also talk about renting dental chair. So Is that a common practice of traveling dentists, if you will? Can you just tell us a little bit more about that and how that is cost efficient?
Yeah, definitely. So the best thing about Fulcrum Care is that we are looking at different ways that different organizations are meeting the needs for underserved communities, let's say FQHCs or community-based efforts, and we're bringing it all in one organization. And so the practice of providing care in a patient's home is done at a small scale. And so we are leveraging that example because it is a practice that is being done, and we can do that. And in terms of the long-term sustainability of it, it actually ends up being economical as well, because we are talking with FQHCs that maybe they don't use their portable units as much, and they're willing to rent it to us. So even our startup costs for that are low. And in terms of maintenance for that material, it's also very low, and that's in contrast to having to set up a whole dental unit with all the infrastructure. This is something that can be launched very quickly.
Oh, I was going to say, just building off of that point, I think the cost basis of this is something that we've looked at very closely. There's a lot of excess capacity within the dental system because there's a lot of organizations that are not providing care, let's say on a Friday, a Saturday, a Sunday. We're willing to use space that already exists and actually make that more efficient. And so part of our case here is we're going to treat patients that were not receiving oral health services before through Fulcrum Care, but we don't necessarily need to build our own practices. We can rent practices, we can rent existing clinical vans. And given that our focus is actually on improving access for underserved communities, there's a strong case to be made when we sign those negotiations and sign those contracts to really make sure that that's something that is cost effective, so it is aligned with our charitable mission too.
All right, my question is regarding the pilot. You said you're running it as proof of concept to present to the health plan. And what's the level of commitment you have with them? Do you have a letter of intent? And what's the plan if that was to fall through? What would you do?
Yeah. So in terms of the financial, right now the focus is to really run this pilot, and for this slide. And the pilot is broken down into 4 main components, which is onboarding the patients. It's going to be delivering the care, making sure that we're addressing any active oral disease and putting them into routine care and establishing them into routine care, and then also sharing information with a primary care provider. We're going to be tracking a lot of metrics throughout this period, making sure that the unit economics of it and also the outcomes of the patient. And when it comes to us working with the payer, that's the conversation that we're going to be having throughout this period. Right now we will be, and you can talk about this a little bit more, but under a pilot phase, we'll be doing a fee-for-service model and making sure that unit economics works in the fee-for-service model, but being able to tap into additional payments after we prove the outcomes that the payers are actually interested in.
Yeah, I think the closest parallel would be to some of the work that CityBlock did early on. So we'd be focusing on the DSNP plans. And so looking at DSNP plans, there obviously there's existing reimbursement there. And so there's a little bit lower risk there. There's also quite a large population of people who are enrolled in DSNP plans, dual special needs plans throughout the state of Connecticut. There's about 100,000 people. And of those 100,000, the vast majority are either in Hartford, New Haven, Bridgeport, or Stamford. And so we have a very clear geographic focus for where we are launching. It's a question of pursuing those pilot partnership conversations. We were just driving around yesterday. We were meeting with Oak Street. They've been really one of our early partners in conversations. And so for us, a partnership with Oak Street would be ideal here. It's something that we've been exploring with them for several months now. And so that's, I think, an ideal partner would be an Oak Street or a CityBlock if they were in this area. But ultimately, any primary care organization that has a risk-bearing component to their plan would be the perfect plan, would be the good partner to partner with, because at the end of the day, they can share the data, they have a financial stake, and they also, more than a financial stake, they care about this too. And so there's that mission alignment there. And I think mission alignment of partners is something that we really, really value in this stage.
Thank you.
Good afternoon, everyone. I'm Urval Shah, founder of Pixie.quest. When you go to a grocery store, you might have noticed when parent and kid interact with each other, the kid is asking for, "Can I have this candy, please, mom?" And the mom says, "No, you can't have this candy." And this happens all the time. The kids are like, "I want this," because they've got addicted to sugary stuff, to those packed food items, etc. So they get used to eating such kind of food, and that is leading to like 67% of the calories being consumed is from ultra processed foods, and that's leading to childhood obesity. Now, 1 in 4 kids in US is suffering from childhood obesity, and for low income communities, the number goes to 1 in 5 kids. Sorry, the other way around. So kids cannot escape this environment because it's not their fault. It's their peer influence. It's the influence from social media like YouTube, watching those videos, and also family because they opt for convenience. And that's why parents are kind of struggling. Like 3 in 5 parents struggle to make their child eat healthy diet. They do some tips and tricks, and then they kind of try to feed them healthier options. Even some of the programs, like if you see community programs done by CDC, or maybe supplemental nutrition assistance program, etc., they all try to educate the kids, their families, etc., in having daily fruits and vegetables. But those initiatives are very short-sighted. They are like, they happen once in a while. They do not scale in a way that they should be. And long-term behavior change is a challenge. So that's why we bring in Pixie.quest. Pixie is a child's buddy nurturing healthier food habits, and it brings in the behavioral change. So Pixie uses the existing interventions. So what interventions? First is cooking. Cooking is a very prone intervention when a kid and mother or father, they cook together. They get used to cooking and trying newer ingredients. So it gamifies it, it engages kids and parents, and it personalizes it in a way that it's particularly there for their own family. For example, if we look at, so for example, like say 15 plus exposures are required for children to expose to accept new food items. So this actually helps every week, every other week to go through newer food items. Moreover, they can also participate in other activities like cart captain, which is like they can choose what food or what items should go in their grocery cart, and they get rewarded for choosing healthier options or swapping to the healthier options. And it does not just scales it, it tailors it in terms of their family level customization from cuisines, dietary preferences, cooking styles, individual goals. Also, it helps with detailed intervention monitoring. So what's happening right now is the intervention is based on whatever they remember, the parents remember, but this captures real data in terms of healthy swaps, peer influence, novel food acceptance, and all this aligns with budget, their household budget, which is the most important part. Existing programs, either they focus on education and scalability. Nutrition experts do tackle behavior change, but then they lack scale. So Pixie can help be a good partner for all these programs, all these initiatives which are happening, and it acts as a great tool to supplement them. So programs can help, so our product can help with powerful data for those programs, and we can leverage the distribution channel of those programs. And with those health of programs, we can help families who are already spending $2.6 billion every year to feed their child healthier products. Currently, we are trying to target 21 million kids in the age group of 6 to 11, and 4 million of those kids are under the SNAP program. SNAP is Supplemental Nutrition Assistance Program. Pixie helps basically organizations launch and monitor these interventions. So we have targeted 2 different segments. First is the public health programs, which target the lower income population, which is 50% approximately of total. And how can we help is we can help them strengthen the interventions, monitoring and evaluation. And the second part is corporate wellness and payer co-sponsorships, which can help them reduce the long-term healthcare cost associated with childhood obesity or childhood chronic conditions over a period of time. So initially, our target is in this year. We just started in November 2024, and the target is to actually run through to evaluate the product, to run a study to evaluate how this intervention works, to monitor it with 50 to 100 different kids, maybe families. And then in 2026, we are aiming for at least 3 state-level partnerships. Going ahead, at least in next 3 years down the line, 1 national partnership to cover maximum number of kids and families across US. So in existing, like currently we have already partnered with Alivia Consulting to build a childhood obesity coalition. So that coalition will bring together different pharmaceutical companies, payers, and other different industry partners, where that coalition can help drive this change. Right now, along with time's up. All right. So basically, funding will be used basically for the behavioral study, and we want a healthy generation of kids here.
Quick question. So how do you measure the outcomes on this, that what you've designed here and your 1,000 users, your 2,000 users are getting the results that they're looking for?
Yeah. So this is, the activities are both digital and physical. So whenever the parent signs up for that, it asks for different details on what is their family situation in terms of what kind of food they eat, what they consume, etc. The recipes are suggested based on those inputs, and the output, like whenever a kid participates in, say, for example, cooking activity, then the AI will suggest the parent that it will choose between the food which they already like and the food which the parents wants their kid to consume and try new one. And that data in the backend gets captured over a period of time, date stamped. Similarly, like cart activity, like when they fill up what items they want to purchase, like kids want to purchase, it gets filled up in the backend, and it keeps on tracking, okay, they tried 3 new items last week. They experimented with these things, so it keeps on tracking those details.
So you get a feedback loop on what you might need, how you might alter the content that you're presenting, or?
Yeah. So I'm sorry. Can you please repeat the question again on the second part?
Oh, I'm sorry. Well, maybe I'm not asking it properly, but I'm just thinking that as you see the people using this, the users using your product, are you able to begin to tweak maybe the content, the way you deliver this, and so on, to get a better result?
Yeah, absolutely. So we have actually currently launched with like 10 different parents, and based on their feedback on how this should be tweaked, etc. And also that's another feedback, but auto feedback happens, like for example the recipe suggestions. It automatically tweaks the recipes if the kid has already tried broccoli, say for example, and the parents want newer ones to come in, like for example walnuts, then the newer suggestion of the recipe will be from walnuts. It's totally AI driven, so utilizing that tech.
All right, thank you.
Yeah.
I think you got cut off time-wise in terms of talking about your team, and I've read what you've said about your own commitment, but that the other co-members of your team. Can you tell us a little bit about that and how your team is going to operate and their commitment level, please?
Yeah, so I'm fully committed here, but yeah, Kaushik, he is CTO right now. So once this product is tested and proven with this behavioral study, which we are planning to do, then he will be able to give 100% commitment. Currently, he is working like 2 or 3 hours every day, helping me with building the product. Jason comes with experience on digital health. He has built a lot of digital health behavioral change tools. So he helps me design it, and he's just an advisor. And one important advisor is Professor Rafael. He is a very well-known name in nutrition, behavior change monitoring, and evaluation. So he has helped a lot in how to sequence it and how to basically how the flow should work, and what all KPIs should be monitored and evaluated.
Yeah. So my question was about the users. So who's I see you go you had some numbers. I think that's probably one of your first metrics. You can go back one slide. Yeah. So when you say 1,000 users, right? Is it individuals? Is it a household?
Yeah. So 1,000 users are 1,000 kids. There can be multiple kids from same household, but we are targeting 6 to 11-year-olds. So our assumption right now is one household will have one kid in the age group of 6 to 11, most probably. There can be more than one kid, but right now that. But our core users, like what we are trying to sell is we are trying to sell it to those public health programs who are already targeting those children. So this will be a service provided to them so that they can monitor their interventions effectively, rather than reaching out to parents like B2C. We are trying to go B2B.
Yeah, okay. And then the second one is good about the product. So it's an AI product, right? Which is heavily dependent on data, which you're using to drive behavior. So where are you sourcing that initial data? I know it eventually comes from user behavior, but to launch like the initial part of it, like where is that data coming from, and is it any proven? Are you using like already proven strategies and interventions that currently exist?
Yeah. So to address the second question, interventions, we are using the existing interventions which are already done by those programs like cooking or grocery cart shopping, or maybe involving them with some of the activities like scientific activities with experiments for kids, etc. Basically involving them with food, right? In terms of data, we are using some nutrition APIs as of now, kind of integrating them. There are a lot of available there, which tracks all the food items, what are the number of calories there, what kind of impact it can have on the body, etc. Along with using LLM. So LLM is trained with that API in place, and then we are using both the things.
Yeah.
So recommend proper, yeah.
Yeah. Is it? Are you just leveraging existing foundational models, or are you building any part of that in-house?
So currently it's ChatGPT, LLM, along with Nutritionix API built in together.
Okay.
Thank you. It's a great problem to be working on. Just a quick one. In any B2C model, right, becomes important to think about where you start. Like, so to get to the kids, you've got to get to parents. And what are your thoughts about the tip of the spear? Like, what profile of parent or what demographic might be most inclined to start to get that initial traction?
Yeah, so that's a great question. And if we look at the parents, like initially, we are trying for example, those free parts here, like initially this year, we're trying to gather data and understand how it works. We are trying to reach out through schools. We are targeting schools in New Jersey as of now, where there is a good mix of population. So for example, the school where my daughter goes, she has a good mix of population across all, like Hispanic, non-Hispanic, Asian, American, whites, all sorts of everyone, like mix of population. So there is a nice little tool in all the schools called Constella or other such tools, which can help connect with those parents. So it's very easy for me to get access to those parents, reach out to them, get back from them, and I can choose a nice demographic to test from. Yeah. Thank you very much.
Hi everyone, my name is Samson Wong and this is Project Hope. Today, Project Hope is a peer-to-peer mentorship network for patients in the pediatric liver transplant community. Over the next 5 years, it will develop into an entire ecosystem that supports the holistic health and patient-centered outcomes, as well as empower pediatric patients to get involved in things like research, advocacy, and improving the standard of care. This project is inspired by my lived experiences as a liver transplant recipient and developed in collaboration with dozens of patient family members, doctors, and the Society of Pediatric Liver Transplantation. With this program, we aim to promote mental wellness and really leverages those lived experiences in improving care all across the country. Now, let me take a moment to explain why this global network of peer-to-peer mentorship is really important. Imagine this, a child just woke up from their transplant, surrounded by their medical teams, their families, and a slew of beeping machines. They've been given a second chance at life. We also know today that the 20-year survival rate for a pediatric liver transplant recipient is in excess of 80%. In the weeks and months that follow, the well-meaning medical teams for the child will focus on medication routine, on lab metrics. They'll focus on physical recovery and patient stability. They will focus on returning the patient to the outside world, but rarely do we as patients have the opportunity to stop and really discuss the after. We rarely have the opportunity to discuss the what can my life look like now that I suddenly have 5, 10, 15, 20, 40 more years into the future. We don't stop and discuss the psychosocial burdens of transplant, the late nights spent wrestling with our new identity, our changing health, and the whole new set of opportunities that are in front of us. This is where Project Hope comes in. Project Hope aims to fill this gap by developing the framework and infrastructure needed to connect pediatric patients in a longitudinal, one-on-one partnership with patients who have already gone through this process. Through this, we're hoping to improve mental wellness and empower the youth to get involved in their own care. Here at Project Hope, we are building a community that helps every pediatric transplant patient thrive. And in doing that, in our first iterations, we are focusing on peer-to-peer mentorship. We are focusing on combining center-specific, transplant center-specific teams with a distributed online network of mentors to help support these patients. We're hoping that through our connections with these mentor teams, we can support these patients at their point of care, right when they're in the hospital and at the darkest period in their transplant journey. As these patients and their families begin returning home, we want to continue these connections through online platforms like Zoom, text, email, and eventually our own homegrown platform. We want to continue these platforms out and provide that longitudinal support. In each of these pairings, our mentors will serve as a beacon and a lighthouse, helping these patients navigate through this transplant journey. Now, in our pilot phase, in our first phase, we'll be focusing on partnering with 2 to 3 transplant centers where we will operate, iterate, and really seek to understand how we can do this mentorship program correctly. We will be using a validated survey that assesses patient quality of life across 3 critical categories: future health, coping and adjustment, and social-emotional status. Based off of this data that we get and the participant feedback, we'll be able to iterate, fix, and kind of improve the way we do matching, the way we actually design our curriculum, and all those things that make this program more sustainable and applicable to other communities as well. To do this, we need a team, and I've built a really, really good team. The idea is that I have experts, field-leading experts from all the various facets of transplant. I've had pathologists, research specialists, patients turned physicians, as well as behavioral health specialists, as well as nonprofit leaders. On my operational team, I have fellow transplant recipients like myself who together bring experience in nursing, in social work, and youth program development and in education. And together, we bring decades of critical experience and passion to the Project Hope board. When I was transplanted, the goal was to get the patient to survive the next few months, maybe a year or 2. But now we are seeing, due to advances in medical care, more and more patients transplanted as children reach adulthood. And Project Hope is being developed at this very exciting time. We have the capability to address things like medicine adherence and the transition of care from pediatric to adult facilities. In doing that, we help address 2 of the most critical drivers of acute rejection in the transplant community. With our high impact and low-cost model proposition, the Thorne Prize would allow us to launch as soon as this summer, enabling us to sustain this organization for a multi-year period. And with the support of the Thorne Prize, we will be enabled to make impact on a systems level scale, not only on an individual level scale. We can reduce the burdens of the transplant system and help more children receive life-saving transplants. I want to leave you with this. Transplant and more broadly chronic disease is a lifelong journey. We here at Project Hope have the opportunity to leverage our shared insights to build connection, resilience, and community. We have the opportunity here to build a community that says to every single sick child out there that there is hope. We are saying to them that there is light at the end of the tunnel and that there is another side to this darkness. And it is saying that you as the child can do this and that we can do this, that we can do this together. Thank you.
Yes, so my first question would be, who qualifies as a mentor? Like, who are going to be running those? And how many pediatric transplant patients exist today in the U.S.?
Yes. So a couple parts to that question. So who qualifies to be a mentor? In our pilot phase, we will be recruiting mentors directly from the transplant centers themselves. They'll be recruited to us by recommendation. We want people who have a well-managed condition, who have worked well with their medical teams, and have competencies like being mature in their own care, being motivated to help others. Those are the key elements. And then later, when we open this up more to the general public and hope to expand our network, we'll be running background checks to ensure the safety of our mentors and mentees in this pairing process. So in talking about the second component, like who is our target audience? It is these pediatric transplant patients. And every year there are over 2,000 pediatric transplant patients that happen in the US alone. This is a program that can be expanded also globally, and we hope to do that through our partnerships with international networks. Because transplant is such a lifelong journey, it's not just at the point of care, but it's a lifetime. What we're looking here, what we're advocating to do is provide point of care. Immediate, as soon as things start happening, we are there. But we are also supporting these patients as they grow up, as they age into college, as they age into adulthood. We are building an ecosystem where transplant patients thrive.
How would you describe in one or two sentences what you think your main innovation is in terms of, there are programs for other diseases that seek to do this, and I mean, look, it's incredibly important, but to the degree that the prize is an innovation prize, how would you describe it?
Yes. We here are building a framework and a thing that can be transplanted to other areas. What we're doing, one of our greatest strengths is our cooperation and our integration. The key thing is, while many mentor programs do exist out there for different communities, what they're not doing is our level of integration. What we're doing is we're actually going directly into the transplant center and setting up center-specific teams. For example, Cincinnati Children's, one of the biggest transplant centers, will have its own team. This allows its team to be culturally sensitive to the practices of that center and the communities it serves. It is that key. It is the idea that each community is different, and because each journey is different, we are building this very personalized approach. On top of this, we are a two-layered structure. We have these transplant center-specific teams that will be important for each of the cultures all across the world. But the idea is that we also have this umbrella network. This umbrella network allows us to address patients who may not be at a center yet. So we have this multi-pronged approach in which we address people at centers, but people who are also not there. And in addressing the underserved community, we also hope to build an ecosystem in the idea that transplant itself is not an equitable process. The 6 months pre, peri, and post cost over $870,000. And so the evaluation process of actually obtaining an organ is actually really rigorous and selects against those without resources. We're hoping to leverage this project, this form of connection, and these distributed mentor network to address these people and increase access to transplant. It is that idea that we are increasing access, that we are building a movement that makes us innovative. It's not just a network, it's not just a mentorship program, it's an ecosystem, it's a community.
Okay, thank you.
There we go. The mentors, they are they're volunteers. They're paid. What's their time commitment on something like this?
So in our first phase, these mentors will be recruited directly to us from the transplant centers, and they'll be working on a volunteer basis. As we work through our pilot, we actually do intend to start hiring full-time staff and have mentors on staff, which will be a part-time job of sorts.
Part-time.
Yes, and it'll be a part-time job of sorts. We'll eventually start building out a homegrown platform, a website, where essentially patients can come and use it as a landing page to ask their important questions, and we'll also have mentors staffing that. So we're building an entire community around the idea of mentorship. We're starting with mentorship, but we'll eventually turn into something with part-time employees, full-time employees, and the Thorne Prize will help us drive towards there. I've said it in some other presentations, and the idea is that we right now have the dominoes lined up. We are ready to launch as soon as this summer. We are ready, and we have the people, we have the idea, we actually have the partnerships as well. We just need a catalytic push. We need that first domino to go down and allow us to have this chain effect, and that's what we're here for today.
I'll be very brief, but I really appreciate this presentation. And my daughter has a rare chronic disease. She's not she hasn't had a transplant, but I have seen firsthand with her the power of like peer connection and how that has influenced her both psychosocially and probably also her outcomes, right? So I'm curious about, like, I see the value in this, but I hate to say it this way, but like the economic model, like how do we tie like this kind of benefit to maybe improved outcomes or something that also shows that this actually supports the longevity? Because once we do that, then it helps us make that sustainability case, because this is a really important issue.
Of course, and this is something that we are at the start of this. We are partnered with the pediatric liver transplant community, and in doing so, we actually want to understand to what extent peer mentorship can be leveraged in chronic disease. This is starting in transplant because that's where I have my experience, but it is for all chronic disease, and it's the idea we're using this validated survey to track outcomes. The Pediatric Liver Transplant Quality of Life Survey is a validated survey that tracks outcomes longitudinally. We'll do this, and we'll also track outcomes on a larger scale, talking about our patients, the people who actually receive mentorship. Are they as likely to miss a medication dose? Are they as likely to get retransplanted? Are they as likely to contribute to the economy in the way that we would have to retransplant them and take them out of the workforce, right? If we're talking about economic benefit, that is also a critical thing. Transplant is not in isolation. It happens with its community members. You need to pull in caregivers. So there's a large economic cost to it as well. But what we do is we seek to understand that. But we know that by improving those things that we're talking about, we can improve the economics of it. From a more personal side, the idea of actually having a mentorship, having a mentor, and having lived through a chronic disease, it has instilled in me like a confidence and a drive to do things like this, to come out here and pitch for the benefit of others. And what we're doing is we're investing in that system. We're investing in the idea that when we help patients at their weakest, at their youngest, we can have benefit that goes on for years.
Thank you.
Thank you.
Hi everyone, I'm Jack, and I'm representing Respond Crisis Translation. I'm a PhD student in public health at Yale, and I've been a long-time translator with Respond in Mandarin, Arabic, and Spanish. Now, I lead on academic partnerships and public health. While I'm here today as an individual, I'm representing a global collective of more than 2,500 translators and interpreters around the world, providing language access services in more than 180 languages. And we work with anyone experiencing crisis or a situation where language is a barrier to support. Every month, Respond translates and interprets for thousands of refugees as they navigate complex immigration pathways, get medical and psychological care, and access education, job, and social services. Without translation and interpretation support, our clients would not be able to get the legal or medical support they urgently need. I want to share the story of one of our clients, Carlos. Carlos fled Brazil after his son was murdered in front of him and was then detained in California. Isolated as a lone Portuguese speaker, he asked ICE officers for an interpreter 10 times and was ignored. Carlos got COVID, almost died, and still was denied language support. One of our interpreters intervened and connected Carlos with a legal team to fight for his freedom. They helped him access medical care, get out of detention, and get asylum. Today, Carlos is living with his family in the US. There are thousands more cases like Carlos's. Our team supports folks forced to flee Gaza, Lebanon, and Sudan, as well as Ukraine, Afghanistan, and Haiti, among other contexts. Our work is the bridge, allowing the nonprofit community to actually communicate with their clients across contexts. From emergency resources and support, housing, immigration and asylum pathways, legal support, public health information and resources, medical and psychological care, education, jobs, and social services. Our partners include organizations as large as the UNHCR, IOM, and IRC, as well as volunteer-led grassroots collectives. We work on a sliding scale and never say no to cases. Our pro bono work with individual refugees makes up 60% of our overall caseload. Earned revenue from paid projects with our large budget partners makes up 50% of our $1 million annual operating budget, while the other 50% comes from grants and donations. This allows us to support a leadership team of 20 part and full-time staff, the majority of whom are themselves refugees who are directly impacted by the crises our work addresses. In addition to our staff, we have created jobs with dignified wages for 680 linguists who are themselves refugees, deportees, or living in active war zones. We built out a robust training program for Indigenous and marginalized language speakers to be able to plug in as interpreters in high-stakes detention, asylum, medical, and emergency response contexts. On the slide behind me, Izzat and Farah shared their stories of how they joined Respond and have been able to improve their translation skills while supporting their families and communities. Over the past 5 years, since our founding in 2019, we have obtained 501c3 status, and the value of the work we have done completely for free is over $5.2 million. The scale of our work grows exponentially with each global crisis, including the immigration crisis we are seeing unfold under the current administration. Since January, our caseload is 5 times higher than it was last year, and our cases are on average 5 times longer. We have vastly expanded our infrastructure since 2019 to meet the ballooning need for our services, but projections indicate that by 2050, there will be over 1 billion climate refugees, 10 times the current number. In order to continue scaling our reach to meet this anticipated need, we are building an application which will leverage AI tools to analyze case outcomes, assist in processing text and audio, categorize documents, and provide training simulations, reducing current workload for linguists by 50%. Additionally, our new platform will use an AI-powered algorithm to match linguists with our partners, reducing the manual labor currently required to manage projects by 80%. Over the next 12 months, we will expand our engineering team, finish up our centralized platform, and launch AI tools to analyze case outcomes. Then we will start work on our mobile app. $25,000 from the Thorne Prize is the seed funding we need to make this platform a reality. Thank you.
Thank you so much. A very important work, and you've gotten some great traction so far. What would be helpful for me is just kind of understanding a little bit more about the model. Like, so where do you work? How does it work? How do these people find you, or how do you find them? And just kind of take us through the workflow. And
yeah, absolutely. So I mentioned our network of over 2,500 linguists. They're based all over the world. So we have a lot of folks based in the US, in Colombia, in Argentina, in the UK, in Germany, in Afghanistan, in Gaza, in Sudan, etc. How folks reach out to us, so first we recruit our linguists mainly through word of mouth. So because the work we do is so sensitive and because we're in need of these highly trained linguists, oftentimes when a crisis is occurring, for example in Ukraine, we will recruit a team lead in Ukraine, and then through their networks, they will reach out to other linguists that they know and recruit on the ground, as well as through Google Ads, things like that. How our clients find us is largely through word of mouth, because a lot of the places we work in are involved with refugee resettlement, helping with migrants, et cetera, social services. And because those communities are so tight-knit, those organizations will oftentimes refer us to other organizations. A lot of our clients are small to medium-sized law firms, as well as these larger NGOs or multinational organizations.
Super interesting. So yeah, so it's like a responsive model. It sounds like you work everywhere. So then how do you enable the linguists now? So like, because what tools do you put in their hands, or how does it work? Like, so, you know, you see a new hotspot where you want to go and offer these services, and then you identify linguists. Like, how are you enabling them to do the work?
Yeah, so the linguists, oftentimes they are trained, maybe they got a master's in translation or interpretation where they're from. In addition to that, our kind of novel addition, and that sets us apart from other organizations, is that we include this trauma-informed training. So oftentimes when someone works in a translation or interpretation context, they themselves can suffer from vicarious trauma. Perhaps they're a refugee, they're resettled, something like that, and they've experienced similar things to what they're translating or interpreting for. So on top of the training they might already have, we add on this piece of vicarious trauma training in order to minimize harms to the translator or interpreter, as well as some of the training programs that I mentioned with some of our folks in various parts of the world.
Great, thank you.
Yeah, thank you.
You show a slide with a big team that you've put together, but I'd like to understand more specifically how you function as an organization.
Yeah. So I mentioned our 20 full and part-time staff. That's made up of our 2 co-founders, our CEO and COO, who are based in San Francisco and Berlin.
And neither of them are Yale people?
Neither of them are affiliated with
Okay.
Yale, yeah. So I'm the Director of Academic Partnerships and Public Health. And so in addition to me, we have our Director of Outreach, who's based in San Francisco, and then we have a number of language team leads. So we talked a little bit about the way that the translations and interpretations are actually done. All of these linguistic teams are managed by an individual on our part or full-time staff. So there's a Spanish team lead, there's the Haitian Creole team lead, there's an Afghanistan languages team lead that are based all over the world. Does that help?
Right, yeah, and then my other question is, well, funding's always helpful in any organization. Talk a little bit more about why the Thorne Prize would be catalytic.
Yeah, no, that's a great question. I think one way that it's really catalytic is, especially at this critical juncture, that we're seeing AI becoming incorporated into more industries, more organizations, et cetera. And there has been less of that, perhaps, in the nonprofit space. So one thing that we're really seeing now is that we have the talent. We have these linguists all over the world, and some of the bottlenecks are represented by the time it takes to get a project to a linguist. So kind of sharing a little bit more about our format, someone can either submit a document to be translated directly on our website, or a client, a law firm, a UN organization reaches out to us and says, I need this in-person translation in Chicago on this day. One thing that makes that, one of the bottlenecks there is the time that it takes for a document to be assigned to a linguist. With our AI portal, and what we're hoping to do is to build on the back end, a portal where a linguist can log in and say, I speak Ukrainian and Hungarian. Are there any translations from Ukrainian to Hungarian that I can do right now? Limiting our time that it takes to assign these translations and interpretations to linguists, and ultimately their overall processing time. Because I think we see the talent exists, the problem exists. It really is just the processing time.
Okay.
Yeah.
Yeah, though you're solving a really big problem. As an immigrant myself, I understand, the problems those people face. So, yes, and automating that process as well, because it's kind of a marketplace, right? Mm-hmm. Where connecting people. So the manual process we automated our process, and it decreased wait time from 6 hours to 30 minutes. Mm-hmm. So that's super important. But you mentioned you had part of the services were free.
Yeah.
Are there any paid services, and what part of operation costs? You have $1 million a year budget.
Yeah.
Does it cover?
Yeah. So I mentioned, anytime that an individual approaches us directly, so a refugee, an immigrant, someone who's in the US and says, I need my birth certificate translated from Haitian Creole to English or Spanish to English, we'll always do those requests for free. We never say no to a case. About 50% of our work is that pro bono work. The other 50% or so is the actual paid fee-for-service work, where a law firm will come up to us and say, we need this translated, or we need this long case translated. The way that we cover those additional fees, or the pro bono work we do, is that we charge organizations on a sliding scale. So our largest partners, who have the largest annual budgets, will charge the highest per page or per minute or per hour of translation or interpretation required. Then our smaller partners, our grassroots collectives, our small groups, a neighborhood organization in New Haven will charge them the lowest rate because they don't have the largest budget. And so it's the kind of the overflow, or the extra, the surplus, I suppose, from those largest partners, what they're paying, that helps us to cover the pro bono work.
All right, so it's a cross-subsidization model where, and you don't end up with deficits, you're not burning through money year over year.
No, so we're not burning through money, and also a lot of our languages, so languages where it's easier to find folks that are have a high degree of ability to translate or interpret. For example, we have a lot of folks that are really skilled in Spanish and English. Those interpreters or translators are paid the least, whereas a more high demand language, or language that's rare, or the folks that are doing that work are in a more sensitive situation. For example, we have a lot of folks who are in Afghanistan who, when the US withdrew, are now women who are in their homes and can't work outside, and this is their source of income. Afghani languages are always paid. Haitian Creole is always paid. So it kind of depends on the language and also the organization that's paying us. So I guess the inflow and the outflow are two different questions. I hope that answered and didn't add more confusion.
Yeah.
Yeah.
Just real quick, this is probably a long answer, and we don't have time for a long answer, but AI. So, that's going to impact a lot of this translation work. Mm-hmm. Is that right? So, have you factored that into what the outlook is on what you're going to do? That could be very helpful to you, obviously.
Yeah, no, absolutely. So I have a couple of different answers, and I'll try to be brief too. So the first answer is that one of the largest reasons that asylum claims are denied is because of mistranslations. So when folks go into a Google Translate or something like that, that I know isn't the top language translation AI, but when someone goes into Google Translate and clicks Spanish, that's not differentiating between Ecuadorian Spanish and Colombian Spanish and Uruguayan Spanish, right? It's all kind of homogenous, this is Spanish. Where we know there are these differences between countries and even within countries, between dialects, varieties, et cetera. That is getting better, and we acknowledge that, and that's why in part of our AI model that we're hoping to leverage is going to be kind of a private, broken off AI model or large language model based on our cases that will be overseen by our kind of data safety monitoring person, and then we'll be able to train, because as I mentioned too, a lot of the work we do is on these less commonly spoken or indigenous languages or minority languages or languages that are more commonly spoken but less commonly written. So the training models or the training sets just don't exist as much for those languages. But we're also focusing more on leveraging AI to maximize our workflow rather than doing the actual translations, interpretations themselves.
Thank you.
Yeah, thanks for your questions.
Well, thank you to the teams for all of your hard work, and see you at 4:45.